Hi, I'm Sean Mooney, Professor and Chief Research Information Officer of UW Medicine at the University of Washington. In this video, two faculty from our Department of Radiology will present a talk titled Challenges and Opportunities for Artificial Intelligence in Medical Imaging. Please be sure to register for our mailing list using the link below to be alerted to future talks and videos. We hope you enjoy these.
All right, hello, welcome everybody. Welcome to our second ever seminar in our AI and Data Science in Medicine seminar series at UW Medicine. Today, the title of our talk is going to be Challenges and Opportunities for AI in Medical Imaging. My name is Noah Hammerlin. I'm a postdoc in biomedical informatics, health economics. I'm also a member of the planning committee for the seminar series. So just before we get started, I want to make note of a few things. Make sure that you are registered in REDCap. Not only will that give us the ability to check your information, but also we're going to be recording these series and we'll make these recordings available to people on REDCap. So I just put in the chat the link to sign up for the REDCap. So please do so if you haven't already. I also want to draw our attention to the next of this seminar series in 2 weeks, November 16th, Monday at 1 Pacific time. That'll be the speaker, Anat Matabushi. The title of his talk will be Artificial Intelligence, Radiomics, and Pathomics, Implications for Precision Medicine, and he is out of Case Western University. But to get us started for today, I want to first introduce Sean Mooney, the Chief Research Information Officer at UW Medicine, and he's going to give a brief introduction to today's speakers.
Hello, everyone. Thank you again for joining us. Really looking forward to this presentation today, and just wanted to highlight a couple of things about our speakers before they get going. So we're joined by Dr. Dushyant Sahani and Dr. Christoph Lee. Dushyant joined us in March of 2019, I believe, as chair of the Department of Radiology. He originally received his MD degree from Mumbai University and was then at Mass General in Boston and at Harvard for 20 years before being recruited to the University of Washington last year. His focus is on investigating new CT technologies such as multi-energy scanners and their impact on patient care, safety, healthcare, cost, and CT workflow. He's published more than 335 peer-reviewed original articles and has appeared in really numerous journals and has given over 300 lectures nationally and internationally. So we're really excited that he is here today to contribute to this presentation. After he makes gives his presentation, Dr. Christoph Lee will present. He is a professor of radiology at the University of Washington and an adjunct professor of health services at the UW School of Public Health and a staff physician at the Seattle Cancer Care Alliance. He is very well educated. Dr. Lee earned his bachelor's degree from Princeton University, his medical degree from Yale University, and then completed his residency at Stanford University. He completed a breast imaging fellowship and 2-year health policy fellowship as a Robert Wood Johnson Foundation clinical scholar at UCLA, and then also earned a master's in health services research. And he has an MBA in healthcare management from Johns Hopkins University. He's published more than 150 peer-reviewed journal articles and chapters, and both of our speakers serve on numerous editorial boards and other advisory boards. So we're really excited. Both of them are giving us an opportunity, are going to present here today. So with that, I'm going to turn it over to Dr. Sahani, who will tell us, get us kicked off here.
So thank you, Noah and Sean, for that kind introduction and for this opportunity to speak in this seminar series as a part of Institute for Data Science and AI for University of Washington. Now, for my disclosure, I'm a recovering Bostonian. As you mentioned, for 20 years, I lived in Boston, so that's a loaded term. And those who are from Boston, they understand it's a mindset and an attitude issue, because that's what you feel you live in the center of the universe. Now, the second disclosure is I'm not an expert in AI. And so that combination is really disastrous. But I will give you my perspective as a department chair and a radiologist, what I feel is the value as well as challenges with AI. Now, radiology as a field is relatively young when you compare to other domains of medicine. Since the inception of X-rays, more than 125 years back, there has been many advances, especially in the last 3 decades. The advances in innovation and new technology has completely transformed medicine, and the pace of innovation continues. So we have seen gain both on the resolution side, the kind of details we can provide on images, but also we are moving more towards functional and physiologic imaging. Hybrid imaging is a prime example. A lot of imaging now, almost all of them are quantitative. And certainly this has paralleled with the growth in other areas in medicine. Now, due to these benefits I described in my previous slide, the adoption in clinical care of imaging has led to exponential growth in imaging utilization in the United States. The numbers for 2019, about 80 million CT scans and 40 million MRI exams were performed, predominantly in adult population. Although oncology was the main driver, there has been a tremendous penetration of imaging in other areas and specialty. Acute care, for example, most of the big decision for trauma, stroke, acute abdomen, to name few, is undertaken with imaging. Actually, ED practice has been revolutionized due to CT scanners, and most of the busy ED and level 1 trauma have CT, MR, and other equipments right near the site of patient service. Cardiovascular imaging has been transformed with imaging and innovations in imaging. It's rare that a invasive test is performed for diagnostic purposes. The diagnostic test has completely moved to non-invasive, and I'm just showing you a case example in a young patient who presented with chest pain, and there you can see a high quality normal CT angiogram done with a less than 1 millisievert radiation dose. Other areas which are contributing to supporting patient care as well as increased utilization of imaging is in the neurosciences domain, especially with MRI. Image-guided procedures is moving at a pace that has not been seen before, but also screening for cancer as well as for non-cancerous indication like cardiac risk, imaging is approved. Now, all this is possible because imaging tests are safe. Most of them are reproducible. The image quality is spectacular. The referring physician can actually look at those images to make decision. We can quantitate data, and this has been supported by image processing and computation. Now, when you look at the University of Washington health system, we are moving towards a integrated health system approach, or we call it systemness. And the aim here is we really strive to optimize patient experience with at all sites of services, especially now as it pertains to imaging. We need to make sure we standardize all key processes involved in care coordination with imaging, and define what sites of what type of procedures we need to offer depending on the complexity, patient location, and as well as local expertise. Now, the whole overarching aim is to deliver patient-focused, efficient, and high-quality care. And I think this is some of the big priority for health system, and of course, this is going to reduce cost by adding more value. Now, when you look at the patient experience and care coordination with imaging, you realize there are many components in patient journey, starting with exam scheduling. And as we have seen with the explosion in digital health, especially the telehealth during this pandemic, we know patients seek more autonomy. They seek more control with their health. So right from scheduling, patient would like to have control with online scheduling. We want to have smart scheduling option based on patient's zip code. We want to make sure the site of service is less than an hour from their zip code, looking at the complexity of the patient and deciding what type of slots or exam time we will be using. This is specifically valuable for MRI, which takes longer. The image acquisition piece has to be personalized following guidelines, not just for oncology, but for also cardiovascular and other application. The data interpretation, there is a need to have actionable reports following lexicon and be more quantitative, especially for oncology. And finally, our result communication, how we deploy evidence-based medicine in making recommendations while providing consultations and also ensuring that follow-up visits have also been scheduled for the patient. Now, patient access is very important, and sometimes to make it easier for patient, we have to take imaging to the patients. Now, a lot of imaging equipments are getting more portable. For example, point of care ultrasound is now being deployed in the ICUs as well as in the ED, and very soon, almost every physician that has been trained from medical school will have a point of care ultrasound instead of stethoscope to do a lot of diagnostic, but also interventional procedures. We are deploying mammogram in a van to reach patients in the communities for screening services. Same approach we might have to take with lung cancer screening. And this might also address some of the issues of healthcare disparities we have seen by taking imaging close to patients, including starting imaging centers and IR procedures areas closer to the patient. Now, just want to share with you where healthcare is moving and how imaging is being deployed. This is an ambulance with a portable head CT that is deployed there for patients who have stroke, where the paramedics can look at those images, and based on if there is presence of hemorrhage or not, they can start a thrombolytic treatment right at the time. And as you know, time is of essence in patients with stroke. So this is the model one is seeing. Now, other problem radiologists are facing is the workplace pressures. And this is due to many factors. One is the case complexity, especially here in the University of Washington, the type of care we offer. We get highly complex cases, which takes longer. We have to meet the expectations of high exam volume. A lot of our time, radiologist time, is spent on non-interpretive tasks, like providing consultations, going into multidisciplinary conferences, scheduling exam, protocoling. And this has been compounded further by decreasing reimbursement. Radiologists are also concerned about their visibility due to the explosion in the digital technology. And all these factors are leading to burnout within radiologists. And this problem has been amplified with the COVID pandemic due to many pressures, including the pressure of finances, as well as expanded hours of services. So clearly, we will have to embrace more technology like virtual consultation, using technology for multidisciplinary conferences, as well as education. And we have embraced some of these technology, but we need to build better platforms which enables a seamless deployment of our services in multiple different areas. So as I share with you a vision for radiology, it's critical for us that we are able to meet this expectation and supporting these different academic pillars, whether it is clinical care, physician and patient experience, whether it's research, education, or operation. The informatics and AI will be a key component supporting all these pillars. So investment in these technology personally for us in radiology is critical, because that will be a backbone or a growth engine for us to support the expectations from the health systems. So first and foremost, I would say for radiology, a radiology informatics platform and tools is critical. We have to have a enterprise-wide integrated IT tool that enables us to seamlessly perform multiple different tasks, whether it is patient scheduling, protocoling, image interpretation, communication, providing feedback. And of course, this requires a great leadership. We will have to invest in a PACS, which is optimized is for both image archiving, but also it has many tools that enables extracting a lot of information and integrating it while radiologists can focus on more high value areas. Report generation has to be optimized following the guidelines and recommendations. Critical result communication is essential because this ties in with the quality and safety. Patient communication is becoming more important, especially after this pandemic. Patient needs to be in full control of their care. So providing patient with the communication on their appointment and updates and also on their reports will be critical. And I think radiology workflow will also be essential. Now we are taking a holistic look at radiology operation. We want to apply a data-driven practice. And for this, we are partnering with Philips to look at comprehensive tool for as a workflow optimization solution and deploying dashboards in different sites of services to support quality, patient workflow, looking at the department finances, reporting quality outcomes, as well as using the data for our practices expansion. And some of these tools, although is using retrospective data, we hope to apply a real-time analytics for decision-making right from patient scheduling, as well as for staffing and changing the sites of services. Now, AI, you all know, and I won't delve deeper into AI, but what we all know that AI is one of the fastest growing area of informatics and computing. And that has a tremendous relevance to radiology because radiology, as you know, is technology intense and data rich. So it's a prime target for application of AI. Now, when I look at the recent PubMed and looking at the publications with radiology and AI, there are more than 5,000 articles published that speaks to the interest and value people see of AI and radiology. Now, I must admit that most of the work has been focused on specific tasks like segmentation, organ segmentation, site localization, looking at lesion detection and classification, the very simple task. And most of the AI has also been applied to CT and MR images, but I think the concept can be extended to all type of imaging since it is a digital data. Now, just to give you an example of task-specific AI algorithms that are currently available, I know there are more than 50 or maybe 100 plus startups who are working at various tasks for AI. We are deploying some of these AI tools in our practice. I'm showing you an example of detection of intracerebral hemorrhage as the arrow points to a small hyperdense area. This is an AI tool to detect a pulmonary embolism, both in a suspected but also unsuspected pulmonary embolism, which is quite common in sick patient and oncology patient. So these tools have been shown to be quite effective in detecting a decent size lesion in different organs. The real value is not the diagnostics. I think the real value for AI in radiology is extracting data. As you all know, I think most of the radiology work is qualitative, interpreting images. But the real value is quantitating or extracting data. We use currently less than 10% of the data that is available for patient care. 90% of the data we don't know how to extract. And the data is in various form, like body composition, like amount of visceral fat or organ fat, the organ volume, the muscle mass, or bone mineral density, atherosclerotic changes, including the radiomics features of the tumor. And these all features have been shown to serve as an independent biomarker for patients' outcome or poor health outcomes in the future. For example, risk for cardiovascular events, future events, as well as stroke. Now, there are tools available to extract all this information so we can stratify patients' risk for cardiovascular and other diseases, as well as risk for outcomes following treatment for various cancer. I think this is another area where AI will have a bigger impact, and a high value indication for AI is integrated diagnostics. And what I mean by that is, as you know, each tumor is different, the outcome is different, and it is dependent on not only on the disease, but patient risk factors, lifestyles, the environment of the patient and the tumor. And if we can integrate all this information along with the lesion details to have a better idea of what is the likelihood of that lesion, even though small, that we cannot reliably categorize, we can predict better risk for treatment decision making, like in this patient with a chronic liver disease, risk for HCC, and so thereby facilitating right treatment. AI-enabled radiology workflow is personally of interest to me, and I hope I have made a case with my previous slides that there is value and interest in utilization of all the offerings of imaging, but we don't know how. And some automation and deployment of informatics and AI is critical. For example, after a patient has been scheduled, we rely on expertise of the technologists to ensure right protocol has been followed, the anatomy has been covered. And if you look at the future prediction, we will have shortage of qualified healthcare workers. So therefore, building these tools are essential to support patient services by automating patient precision or protocols. Image acquisition piece can impact the quality, artifact, the safety, for example, with radiation dose and contrast utilization, both with CT and MR. Interpretation is another area for radiologists. If there are AI tools that can help with detection, classification, segmentation, and quantitation, and can bring in prior reports as well as EHR data for radiologists to deploy then clinical decision support for right management and interpretation. So this is an area where I feel AI will have a big impact for radiology. Now, as a department, there are multiple investigators who are working in different areas on AI and setting up collaboration within as well as outside. And I am so privileged that Christoph Lee, who has been a leader in the breast imaging space, is doing a lot of work as well. So radiology has a lot of interest in this domain, and we need to really lead some efforts with AI. Now, just to share with you that we are rolling out in less than 10 days a collaboration with a AI algorithm company, ADOC, where our data will be prospectively processed with the platform and the software for both the outpatient ED as well as inpatients. These analyzed images will have reports. There will be widgets on our workstation for radiologists and the trainees to interpret. There are few areas where they have FDA approval, and so we will be deploying in all those areas. For example, looking at hemorrhage or vessel occlusion, fracture of cervical spine, pulmonary embolism, intra-abdominal air, but there are some other areas where we will be doing research, but also we have our own ideas of co-developing few tools with AI. Now, having said that, all the excitement about AI, there are real barriers and challenges for AI in radiology. We certainly, know there are, AI has promise, but we need to train these algorithms. We need a high volume data, which is diverse and also well curated for diverse types of problems for validation. We need to have more task-specific solution which can be integrated in radiology. Most of the work is retrospective. We need some prospective multi-center trials in a high-value type of indications. We still haven't addressed the regulatory issues for AI. Maybe we might apply the robotics model, how there are some regulations around deployment of robots, and maybe that might be an approach. There are some medical legal issues we need to address. For example, if the radiologist failed to look at the report from AI, what is the responsibility if there was a positive finding and a poor health outcome? How do we monetize this? And of course, how do we change the perception that exists in certain radiologists and overall in the workforce of the threat from AI? Overall, I think AI is going to augment our role. AI will be a great tool for radiologists, and we need to embrace and lead our effort. So in summary, if we need to provide a personalized, efficient, and cost-effective care across the health systems and meet the big healthcare priorities, all these tools of AI and informatics have to be integrated. And we have to create solutions so we can provide that care that we have envisioned for our patient. And with that, I thank you all for your kind attention.
Great. Thank you, Sean and Dushyant, for the opportunity to speak. That was a tremendous overview, Dushyant, of medical imaging and opportunities and challenges for AI. For this portion of our conference today, I'll be taking a deeper dive into breast cancer screening and breast cancer imaging, and specifically mammography, just to kind of delve into some of the issues and opportunities that we have here at the UW. I'd like to first start off with an overview of AI for early cancer detection and breast cancer screening, including sort of the history of using AI, because mammography is the poster child and probably one of the first places in medical imaging we used AI. I'm also going to talk about our experience with the DREAM Challenge and Digital Mammography DREAM Challenge that happened over the last few years, and we've just published the final results this past January. I'll talk about our current efforts at the UW in terms of external validation of promising AI algorithms. And finally, talk about some future opportunities for evaluating the clinical effectiveness of AI at the population level, which will be important for widespread adoption. So AI in breast cancer screening is not a new phenomenon, right? We've had traditional computer-aided detection, and it actually got approved back in 1998. These computer-aided detection algorithms were based on small reader studies, so case sets that were enriched with cancers, and in an artificial setting, different radiologists would interpret the images with and without CAD. And this type of evidence was pretty low in terms of threshold, but was adequate for FDA approval. What was fortuitous for the CAD vendors at the time was that digital mammography was just coming into play, and Congress actually passed Benefits Improvement and Protection Act in 2002, which actually mandated Medicare reimbursement for digital mammography and CAD. So CAD was able to piggyback off the diffusion of digital mammography just by dumb luck. And they were able to get it approved, reimbursed, and that really opened the floodgates in terms of widespread adoption. So once radiologists realized that they could use this added software during interpretation and got reimbursed extra for it, of course, adoption happened very quickly. and upwards of $400 to $1 billion annually in terms of additional reimbursement for screening. Was this a good thing? Well, we learned that it wasn't, right? Again, the bar for FDA approval is super low. And when we actually look through the data over time, several observational studies done by the Breast Cancer Surveillance Consortium showed that adoption and widespread use of CAD actually did not improve accuracy. So for instance, this study from the BCSC that covered all screening exams performed between 2003 and 2009 at 66 different US facilities involving 271 different radiologists, basically found that one, CAD did not improve any performance metric for radiologists. The sensitivity did not improve, their specificity did not improve, and their cancer detection rate did not improve. Second, as you can see from this ROC curve, the actual performance of individual radiologists was quite variable. They were all over the map. And when you actually looked at the overall accuracy, the use of CAD actually decreased overall accuracy compared to radiologist performance without CAD. And this is highly problematic because as adoption happened, it was pretty consistent in terms of CAD being used on almost every mammogram. So you could see here in 2000, in early adoption period of CAD, almost zero mammograms that had CAD. But once there was reimbursement for it with Medicare in 2002, a little more use. And over the next decade, the vast majority of digital mammograms performed in the US had CAD added to it. So realizing that we had this horrible experience with traditional CAD, you could see that why the screening community, at least in breast cancer screening, would be wary about AI and the use for image interpretation. But there is this renewed interest, and the advent of convolutional neural networks, large amounts of imaging data storage capabilities, and greater access to large amounts of digital exams through PACS kind of renewed the interest in seeing if supercomputers could basically interpret better than radiologists. These are just two headlines from this past year. And if you're reading major newspapers and periodicals like the New York Times and Time Magazine, you've probably seen headlines of different algorithms that are coming out with the big splash, stating that they could read mammograms, and even Google saying that theirs could detect cancer better than radiologists. Taking a step back, about 2015, 2016, the SAGE Foundation approached the University of Washington to consider something called the Dream Challenge in digital mammography. They obtained funding from the Laura John Arnold Foundation and were able to put up a cash prize of $1 million to see if coders across the globe could develop a CNN or deep learning algorithm that could outperform the radiologists in terms of mammography interpretation. Led by Justin Gannett and others at SAGE and IBM and UW and KP Washington, we put out this broad call for anyone to participate in this challenge. And if they were able to collaborate, come up with an algorithm that beat the human radiologists based on Breast Cancer Surveillance Consortium standards, they would win $1 million. So just to talk about some of the challenge we had with the Dream Digital Mammography Challenge, of course, we're talking about a large amount of data. This is sensitive data. These are women's images of their breasts, whether they had cancer or not. And actually finding data partners was a challenge. We were able to get buy-in from Kaiser Permanente Washington and Diana Buist, who leads the breast cancer screening registry here in Seattle, to be able to use several years of imaging data. These were de-identified images shared to Sage as honest broker, along with clinical metadata and robust clinical outcomes with linkage to cancer registries for ground truth. Normally, when you're talking about training and validating an AI algorithm, you basically hand over this data to those that are developing the algorithms. So basically handing over the training and validation data and hundreds and thousands of exam data was not appealing to KP Washington and was basically a non-starter, as it would be with most health systems. So Justin and the leadership team had to think about a new approach. And I think a lot of you folks that are in the AI realm understand this model to data paradigm that I'm about to talk about. But really what this does is addresses the health privacy concerns. Instead of in the normal data to model practice where you have basically delivery of images and data for training validation to participants, in this case, all that validation data set and prospectively collected data stays behind a firewall. Instead, a very small subset of the training data is released to challenge participants, and they're allowed to train and create their models. What they would do is basically containerize that model in Docker form and send it back to Sage to have their model tested or basically validated against the larger complete data set, scored, and then fed back to the challenge participants to iterate on. They're able to use their own training data from other sources, but in terms of Kaiser Permanente's data, that stayed almost the vast majority of that data behind a firewall. This appeased privacy concerns, but even with this approach, finding large data sets with robust clinical outcomes was extremely difficult. And for an independent external validation, we did finally eventually find a partner in Karolinska Institute in Europe, but approaching several different breast cancer surveillance consortium registries in the US, they were reluctant, mostly because of health privacy concerns. So overall, we had 1,100 participants comprising 126 teams from 44 different countries that participated. We asked them to develop these algorithms, and then we scored their accuracy based on their AUC value, and also at a point estimate in performance where their specificity was compared to Breast Cancer Surveillance Consortium radiologist specificity, where we set the sensitivity to the radiologist sensitivity. KP Washington made available 144,000 screening mammograms from over 85,000 women for both training and internal validation. The end result was that no single algorithm was able to outperform the human radiologist. There are obviously many limitations in terms of the lack of supervised learning. However, the end result was that even the best performing algorithms from the best teams across the world could not develop one that beat the radiologist performance. However, we did what's called ensembling modeling, which is where we combined the best performing algorithms together. And then we went a step further and actually combined the best performing ensemble models with radiologist performance at the exam level. And when we did that, we found combining the top performing algorithms and radiologist assessment led to an AUC value of 0.942, which is quite high when you think of the fact that radiologists perform around 0.90 to 0.91 by themselves. So this ensemble actually achieved a significant improvement in specificity at the same sensitivity, meaning that at a point performance on this curve. If we set this ensemble model to have a cancer detection rate similar to radiologists, we were able to prevent a large amount of false positive exams. So decreasing the recall rate upwards of what we estimate to be about 500,000 recalls eliminated each year in the US. What was really interesting when we evaluated this with an independent test group at Karolinska Institute in Europe, completely different screening population and methods. They have double reading in Europe, whereas we have a single human radiologist interpreting mammograms in the US. And when we take the first reader in the Karolinska Institute and run this ensemble model, we get extremely similar results. You can see from A being the US population and B here being the single reader in the Karolinska Institute population. Again, the dark curve being the combined radiologist and ensemble model. The highest accuracy was in the combined ensemble model. What's interesting when you go from figure B to figure C, this is the single radiologist in Europe to the double reading in Europe. There is very little gained when you actually add that second human reader. So what we're seeing here is one, that we do confirm that this ensemble model improves radiologist accuracy in a completely different patient population. But we also see that it really helps in the single reader setting where AI could serve as an effective double reader. So the lessons learned that we took away here at the UW was one, that the multi-data paradigm that Justin and others pioneered for algorithm validation testing can address privacy concerns and be effective. Second, that this is especially true when you have a central honest broker, as the Sage Foundation served for the Dream Challenge. And this is a minor point, but an important point. You've heard about federated approaches where algorithms can be shared across institutions, but actually having all of the data images in one central place allows for uniformity in terms of how models are validated. And it actually protects the vendors as well. So if you're doing comparative algorithm validation like we did for the Dream Challenge, the fact that the Sage Foundation served as a central honest broker was appealing not only to the data, the folks that supplied the imaging data, but also to those that were actually creating the algorithms. And another interesting point of contention among participants was whether we had robust ground truth. So for the Dream Challenge, we only needed, or said that we needed 12 months of follow-up data to determine if a screening mammogram was a true negative or a false negative. And some participants thought that this wasn't enough. Theoretically, they said that their AI algorithm could detect cancer way earlier than a human could, or way earlier than a cancer would be detected clinically as a palpable mass. So that was a very interesting point that they brought up that was very contentious because it did influence whether prize money was given out or not. Since the Dream Challenge, there's been an explosion of commercially available FDA-approved AI algorithms. As Dushyant mentioned, there are more than 75 FDA-approved AI algorithms across medical imaging for image interpretation. Several of those are now for breast cancer screening, and both for 2D and 3D mammography. And as we've mentioned, case sets used in these small reader studies number in the hundreds, and they're enriched with cancer positive cases. They're not what you would see in the real world setting. And so the bar for FDA approval and for direct marketing to patients and providers and health systems is extremely low. And what will happen from here on out is entirely unknown. What we don't want to do is have a repeat of traditional CAD diffusion, where these unproven technologies are adopted at a rapid pace for something as very delicate and very politically charged as breast cancer. And what we need to do is evaluate these in a population-based manner and in a robust manner that will garner the evidence that could feed into decisions for changes in guidelines for screening and also for reimbursement and payment. So this is a pretty busy slide, but this is an overall conceptual framework of how the University of Washington is approaching robust AI algorithm evaluation for cancer screening algorithms. And what you're seeing here from left to right is a progression from early stages of evaluation and technology efficacy, and all the way to the right to a population level approach and the type of evidence we're going to need for widespread clinical translation. What I would like to point out is that we're at a very early stage. Even with FDA approval showing some improvements in potentially AUC, sensitivity, specificity values based on small reader studies, we're nowhere to the point of showing overall outcome efficacy or societal efficacy in terms of things like false negatives, positive predictive values, things like breast cancer deaths averted, quality of life year changes, and associated costs. And until we get to this right end of the spectrum, you're not going to have the widespread clinical translation or even reimbursement. So what are the stages and steps we need to take right now in terms of technology evaluation to get to that point? I think the first thing is to realize the majority of what's been published so far and that have hit the airwaves are algorithms that have been trained and potentially internally validated with the same data set used to train and develop the model. Some have done external validation, but potentially not in the exact targeted populations for these algorithms. And like Dushyant mentioned, all of this has been retrospective convenience samples of data that developers could get their hands on easily, but none of them have really broached the subject with prospectively collected data. Once you have valid external validation, robust external validation, then you can start moving on to actually implementing those, seeing how that affects your clinical workflow, seeing how that compares to other technologies for screening and how that impacts outcomes per cost. As we do this external validation, we have this feedback mechanism where we're continuously allowing these vendors to improve their algorithms. And you need this continuous feedback and continuous improvement before you could say that, okay, these algorithms are pretty fantastic. They could rival human interpretation or improve human interpretation, and then we can move on to the prospective studies. So let's take a deeper dive into external validation in target populations using prospectively collected data for breast cancer screening. So in terms of barriers, a recent systematic review of publications of AI for medical imaging found that only 6% of them actually perform some type of external validation or independent testing of their algorithms. Again, the vast majority basically trained and internally validated their model. That means they just took a small fraction of the data they started with and randomly split that from their original data set and then basically validated it in the same population. What this split sample internal validation does, it basically over-parameterizes your classification model. And then you have this problem of overfitting. And what we mean by that, and you're going to hear this term over and over again in terms of AI validation work, is that these models are too customized to their training data. They may be generalizing on artifacts and certain characteristics of the patient population that don't really apply to what you're really trying to get at with these algorithms. When we break it down, translating technologies in clinical practice currently is slowed by one major barrier, and that's really the lack of high quality imaging data and sources for external validation. And this is where I believe UW can lead, especially for cancer screening and imaging. When we look at the literature, there have been no studies, 0 studies out there in terms of AI for medical imaging that had 3 key elements for robust testing and evaluation. First, external validations instead of internal validation. Second, the use of prospectively collected data. And third, data from multiple institutions. And what I mean by prospectively collected data, it's not that you're going to do the validation work or external validation retrospectively versus prospectively. Of course, you could do it retrospectively. It just means that the data has to be continuously collected. You can't be sampling basically with some external criteria. You want to capture your entire target population worth of data. So how are we leading in terms of AI external validation work in medical imaging? So with investment of Dushyant and the radiology department in partnership with Sean Mooney and his ITS and bioinformatics group, we've created the Northwest Screening Cancer Outcomes Research Enterprise. And what we're trying to do and what we are doing is creating a unique partnership between UW Medicine and community practice and health systems in the Pacific Northwest. What we're hoping to do is aggregate the largest de-identified imaging data set available for breast cancer screening in the US. And the ultimate goal is to improve population-based outcomes. So this big data resource, both for observational studies and for artificial intelligence, will influence regional and national cancer screening policies and practices. There are only a handful of breast cancer screening registries that are trying to do this in the country, us being one of them. And because screening for breast cancer is so siloed in the US, we have no national screening program. Radiology facilities are where all of the imaging data and outcomes data for breast cancer screening currently lie. We have a host of health systems and radiology partners in the region that have verbally signed on, and several are starting to send their imaging data into the UW as the central honest broker. So we have large health systems like VM and Multicare and Swedish, as well as smaller radiology firms like Skagit Radiology, TRA Medical Imaging. And these radiology facilities that are sending us their data are both in rural and urban settings, currently from Oregon, Washington, and Alaska, and we plan to expand. So I know the election is tomorrow, and this is not a political map of the Electoral College. The red states here are actually states where the Breast Cancer Surveillance Consortium Registry, where I'm a senior investigator, has similar cancer registries. So these states and usually cities, so in California, San Francisco, and Chicago, in Illinois, Chicago, have regional or state level breast cancer screening registries where they're trying to collect the data that Northwest SCORE is collecting. Northwest SCORE eventually will be the largest of all of the breast cancer surveillance consortium registries in the US, and will cover multiple states in the Pacific Northwest. Together in the future, our surface area obviously will trump, no pun intended, the red states here. So building off our Dream Challenge experience, where we were able to lead with Justin and Sage that effort, Northwest SCORE is going to continue addressing key barriers for robust testing for mammography and AI. And we're going to do that by having a large, diverse general screening population and partnering with other BCSC registries throughout the country. We're going to include every screening exam performed at these real-world clinical practices. So we'll have the full disease spectrum. And then we're going to link to state level cancer registries in Oregon, Washington, Alaska, and other states as we bring in this data to have robust ground truth in terms of whether a screening exam actually had cancer downstream or not. So taking each of these barriers individually, we know that previous training and development has relied on convenience samples. What do I mean by that? A lot of vendors are publishing papers saying that they have externally validated their algorithm in different population. Usually these data sets are from a single institution or facility, or are from publicly available data sets like DDSM or DMIST, or from other trials that collected case sets in specific populations for specific reasons, not having to do with general AI external validation work when we're talking about cancer detection. The majority of these have also just been validated in European or Caucasian screening populations. And we know that the diversity in terms of race ethnicity is a huge problem for generalizability of AI and mammography screening. And that's why something like the Northwest Score and these registries of the Breast Cancer Surveillance Consortium coming together with racial ethnic diversity and diversity in their patient populations to show external validation of these algorithms are going to be super important. In terms of full disease manifestation spectrums, a lot of the reader studies that are performed to determine quote unquote accuracy of these AI algorithms are enriched case sets. That means that for reader studies that had to do with tomosynthesis, the case sets are going to be enriched for features like architectural distortion, the desmoplastic reaction that happens with invasive ductal carcinoma. But we know that there's this full disease spectrum of breast cancer, starting with your normal appearance and histopathology with hyperplasia, atypia, DCIS, eventually culminating in types of invasive carcinoma and lobular carcinoma. The breadth and depth of the disease manifestation spectrum is not captured in the data sets available for external validation unless you have large enough numbers and large enough populations where you're capturing all of this data. Finally, ground truth. When it comes to AI external validation, your reality is super important. If you don't have a ground truth, you don't know whether there's cancer or not in reality, then you're basically have a gold standard and a ground truth that is false. And you're not going to be able to say that your algorithm is finding cancers the way you want it to. So the majority of labels assigned to images that have been used for internal and external validation thus far in the literature are based on local biopsy records after diagnostic workup. And that is not enough, because what you're basically doing is limiting your ground truth to human observation, only those that are picked up by radiologists that underwent breast biopsy. And that's going to cause a biased result. What we're going to do with Northwest Score is actually partner with state level cancer registries. So 99.9% of all cancers diagnosed in Washington state have to be reported to the Department of Health. We're able to capture rich tumor level data and actual cancer results over a long-term period for each exam that we're collecting data on. So our plan is to collaborate with both the other BCSC registries in the US, as well as vendors developing these algorithms to evaluate them. We're going to do it on prospectively collected consecutive imaging exams. We're going to have data from diverse real-world clinical settings, and we're going to have robust ground truth linkage, all things that are missing in current internal external validation efforts. We've already joined forces with 4 AI vendors that have products that are FDA approved or about to be FDA approved for 2D and 3D mammography. And we're planning to, we've already submitted grants and we're planning to partner with them in terms of external validation for their work. So what does this look like? It's very similar to what we had for the DREAM Challenge, where UW will be a central honest data broker for all the clinical and imaging data across the BCSC registries. We will keep that behind a firewall, and each algorithm vendor will send their model to us for validation on our prospectively collected data sets. And we'll provide a feedback mechanism to tell them how they're doing. And that will inform them in terms of how they need to further train and further internally validate before they could go through this process again. And this iterative process eventually will lead to better performing AI algorithms before clinical trials. So we talked more about external validation. Downstream, we do want to look at targeted uses of AI for workflow. And we also need to evaluate at the population level how these AI algorithms will affect outcomes and costs. So I'm going to briefly touch on these subjects right now. One of the things we like to look at is if these AI algorithms that are able to create a numerical score, so say from 1 to 10, a continuous score for cancer risk on an image, whether we could use that to triage our screening studies. So if we could effectively, with a very high negative predictive value, say 99.9%, show that an algorithm can safely triage negative mammograms, then that could be taken out of the radiologist workflow, freeing up basically a diminishing workforce of expert breast imagers to focus on the exams that are more likely to harbor cancer. ScreenPoint, one of the industry partners, took several data sets and applied their conservative threshold of 2 on a 1 to 10 scale. And in their data set of over 4,000 exams from different facilities, they found that only 1% of exams harboring cancer will be labeled as negative, but radiologist workload will be reduced by 17%. We also want to have a better understanding of how the radiologist interacts with AI algorithms or the user interface. And we think this is where traditional CAD went wrong. We didn't account for the fact that the radiologist is still making a subjective interpretation if they're presented with AI, bounding boxes or information during their interpretation of a mammogram. And at the end of the day, the radiologist does make the final call. How they incorporate AI algorithm outputs and quantitative information into their final decision is a complete unknown. So we actually do have funding from the NCI to look at these specific issues in terms of the user interface and work with one industry partner to look at how different approaches to providing information to radiologists can impact interpretive accuracy and outcomes. We also want to understand acceptability. Dushyant mentioned the medical legal concerns. There are also ethical concerns in terms of whether AI could really drive imaging interpretation with or without radiologists. So this is some work that was done by Nathaniel Hendricks, one of our PhD candidates that recently graduated and is now at the MGH, where he took a health economics approach and did discrete choice experiments with physicians ordering mammograms to see their take on AI-driven screening interpretation. We're planning to do the same thing with radiologists that interpret AI and mammography screening to see what exactly and what features and characteristics are acceptable to them. Finally, some have spoken out recently saying that AI is pretty good. Let's move on straight to clinical trials and randomized clinical trials. And to that, I would say that we really have to focus on improving the algorithms with external validation, independent data sets, in an iterative process before we could get to that stage. Case in point, the NCI is now reviewing TMIS, or the tomosynthesis mammography imaging screening trial, where they invested $100 million to look at tomosynthesis, or 3D mammography, and its diffusion and its impact on outcomes. This will not happen again. $100 million is a huge investment, and what they're realizing is that the technology is diffusing too rapidly. It's already becoming the norm. And by the time we do these several-year randomized control trials, the data is going to be extinct, and the technology itself may have moved on to something more advanced. So randomized clinical trials involving AI currently, in my mind, is highly unlikely, partly because of the years of investment needed for outcomes data, especially for mortality, and the amount of money that it actually is needed to pull off large clinical trials. I think approaches like the one I've outlined today in terms of population-based external validation in an iterative process is going to get us to a better results quicker and provide more real-time outcomes data for decision makers. So in the absence of randomized controlled trials, how do we look at things like the overall costs and the differences in benefits and harms of adding AI to interpretive performance and improved accuracy? What we have in breast cancer and in many other cancers is something called CISNet, or the Cancer Intervention and Surveillance Modeling Network, which are these highly funded, NCI-funded, very sophisticated simulation models of the entire US population for specific cancers. And what you could do with these models is actually change the interpretive performance of tests. So this is perfect for something like AI, where we're looking at changes in values of sensitivity and specificity. And we could actually input these into our CISNet models and see what could happen at the population level. This is basically what we've been doing with newer technologies like tomosynthesis, 3D mammography, screening ultrasound, in order to inform the US Preventive Services Task Force and other policymakers and guideline makers. And this is what we can do in the setting of where randomized controlled trials are just not feasible. So overall, this is sort of just a whirlwind tour of what we're trying to do with Northwest Score, AI just being a part of that. But we're really poised to take leadership in population-based evaluation of promising screening technologies, including AI. And this effort is going to further the mission of the university and the university's population health initiative. I'd like to thank Dushyant for his constant support, and for Sean and his team at the ITS, Mel, Becca, Derek, and others for all the work they're putting into Northwest Score. Thank you for your time. If you want more information about Northwest Score, this is our URL, and you're welcome to email me directly as well.
Thanks, Christoph. There've been those were both great. There've been a bunch of questions and answers in the chat, and I thought maybe I'd kick off the questions. We have some time. Was to repeat a question that Paul Crane asked a few minutes ago, and that is, what's the legal situation when a radiologist thinks a woman should have a biopsy and the model thinks that should not happen? The radiologist has a license and can get sued. The model, not so much.
Yep. And this is where currently it is an unknown, right? We don't have any malpractice cases that we could point to saying AI changed determination one way or another. What's really interesting with traditional CAD and mammography is that the provider, the patients, any type of report going out is from the radiologist, has a radiologist signature. So at the end of the day, the radiologist is responsible medical legally, whether they use CAD or AI or not. And so to really determine whether a radiologist is not at fault is not even a question, unless you have a situation where AI is the only reader, the only interpreter, and a radiologist has never set eyes on a set of images. And we're not at that point yet with anything in medical imaging.
Did you want to add something, Dushyant?
I think I concur with what Christoph has mentioned. And there is a lot that we have to wait for on the regulation side. Because none of the AI tools currently are built to provide recommendation by themselves. You can automate recommendation that you have created in radiology based on guidelines, but no tools give tools give a likelihood of a certain finding or a diagnostic probability in certain cases. So clearly, there is a lot that we don't know yet, but work is being done. Both from our societies are on top of it, and also I think FDA is looking at this seriously as well.
Great. Chetan asks a question, says, thanks for the great talk, Dr. Sahani. You mentioned in your talk that you're working with a company to prospectively collect data to make it AI ready. What were some interesting things you and your team learned while developing this collaboration?
I mean, that's a great question, and you saved me the trouble. I was typing it right now, Chetan. But the thing is, the collaboration is being launched in like 10 days. But main area of interest is not just to validate the already approved tools. My big interest is how do we triage patient in the acute care or those who are inpatients overnight. These are high-risk patients. If AI can prioritize the list and trainees who are overnight can actually look at the AI and see if that's the case, should get attention. How do we create more effective communication with referring providers? And that is another way, because it's a challenge because of the high volume. How do you give a timely communication? Paging, calling can be very disruptive at that time. So if we can build these tools, that's another area. Third area will be risk stratification based on multiple findings and patients' clinical history, and how we pursue those cases more aggressively, because not these tools don't address the entire image analysis for all the findings. Recommendations for incidental finding is another area, because it's a huge cost. Incidental finding and some standardization and automation there is an area of interest. The fourth thing is also comparing a high-end technology and its performance with a low-end technology enabled with AI for diagnostic purposes. Do we need high-end technology everywhere, which are expensive and have a high maintenance cost? Can we use AI to bridge that gap? So those are some of the areas we are pursuing, Chetan, beyond the tools which is approved, they are approved for.
Thank you. Yeah, that makes sense. Yeah. So is it like one of the biggest factors for you is also like taking this data but presenting it in a easy way for physicians to act on it very easily compared to the previous methods? That's one of the biggest things you're working on as well.
Yes, that is another area, is how do we be effective in our communication? Remember, we have a diverse type of radiologist with the experience of being in training or a few years to several years. How do we create a communication loop that is effective irrespective of your radiologist experience? Third area which we are interested, overnight we have trainees who render preliminary interpretation. If AI can help them get those diagnoses right in a challenging situation. Also Northwest, we have currently a teleradiology company that provide prelim interpretation. Of course, we plan to move fully all that work we integrate internally, but we will apply AI to see if AI can serve that task till we move to a full staffing within few months. So, There are a lot of opportunity on the workflow side, communication side. Yeah, the diagnostic is what is more fancy, but I think that's not the real value of AI yet.
Got it.
Thank you. We have a question also in the chat from Shima Nofala. Shima, if you want to unmute yourself, you're welcome to ask the question directly, or I can read it.
Hi, everyone. Thank you for a great talk. I'm very interested in attending this talk because as a computer scientist, I think there is a huge gap in the communication between medicine and AI, especially now that AI algorithms are doing like really, really good. They are fast, they are accurate. I think now it's the time that they move to other areas and help and assist other like areas. And what I think is missing is this, conversation, like what medicine needs from an AI algorithm. Do they want to like give them the accuracy, or do they want to see like how the decision making is, how the decision is made by the computer? And also another thing that I think computer can help medicine is that the decision of the computer doesn't, or like AI algorithm doesn't change over time. So that can help like pathologists in their training, so they know like what the decision was and why it was made and why they are changing their mind now. So it's not much of a question here, but like your opinion about how AI can help, and instead of coming up with like new algorithm to be in competition with doctors and medicine, what you want to get from us like computer scientists. I think I talk like from all over the place, but
Shima, thank you. That's a great question, and I'll just briefly respond, and Christoph, you can take over from there. I think AI, first of all, how you look as a computer scientist on the techniques and data processing, I think it helps us bring our clinical expertise and our challenges to marry that and create solutions around it. I would say personally, I look at AI as a advanced computing to make our job easier. So a lot of things we do, which takes a lot of time, if these tools of advanced computing can augment our role, can it add more value by extracting more information? Can it integrate information? Can it help us prioritize our workflow so we can be more efficient? So I think from a perspective of a radiologist, I am looking at AI to solve a lot of tasks which takes time for us radiologists to do. And we can focus on other things like providing consultation, to meeting patients, and also applying our expertise on highly subspecialized areas. So that way, we can be both impactful without burning our workforce. Christoph, please.
Yeah, no, those are great points, Dushyant and Shima. I think those are good questions. I think that's why our group is looking at the user interface. We think that there is a lot to be learned in terms of how radiologists interact with that AI information. Visually, do they want it on the image? Do they want it separately? Do they want quantitative features? Do they just want a box where they have to look or not look? And I think that's where traditional CAD went wrong, right? They never looked at that user interface. And theoretically, CAD should have improved accuracy, but it didn't, because the radiologists took that information differently at the individual level, and it influenced their final assessment of the images in different ways that we didn't expect. And I think the point about being able to tell what it is that the AI is picking up on is really hard, right? And I think especially with deep learning and the black box, trying to get buy-in among radiologists and physicians and even patients about that black box is something that we have to address. So I agree, it is a big issue.
Thank you for making that comment. Actually, it's interesting. I had a meeting with our pathologists like 2 weeks ago, and they also thought that the deep learning is a black box. Maybe it's our computer scientist problem that medicine things like that. But for example, in my work, when I design an algorithm and I get the diagnosis, I can get the heat map of that image and tell the pathologist where the algorithm is looking at. So maybe it's not as much a black box as it's common in medicine community to think about. So there is opportunity to give the medicine the reason behind this decision, where it's looking at, how much like confident the algorithm is in making that decision. So that's the thing. That's the thing that I think is a gap, is that medicine doesn't know the deep learning that much, and the deep learning doesn't know the concern of the medicine. So this is something that I think these talks can help to come up with the ways that we can solve this gap. Yeah, thank you. Thank you so much for listening.
I think, in computational genetics, different field, still doing machine learning on complex data, I think we saw what I would call a breakthrough about 12 to 18 months ago. And it's really important to understand that methods, whatever the discipline is, the methods are improving accuracy over time. And some fields have seen, really impressive increased accuracy of methods over the last decade. And I think that's something that sometimes we don't appreciate enough.
I must admit that, Sean, that's absolutely correct. We are seeing that in some of the AI algorithms for a task like hemorrhage, intracranial hemorrhage, as more data is being used to train and validate, suddenly these algorithms are so much better and more accurate in the ranges of more than 90 plus or 94% accuracy for detecting a small hemorrhage, better than radiologists in certain areas, especially not subspecialized radiologists. So I think it's clearly there is some value. And one area there is, in the big stroke, they always detect it. It is always a challenge if the hemorrhage is less than a centimeter size or few millimeter size. But you can imagine if in an ambulance setting where you need to know urgently if there's hemorrhage or not to give a thrombolytic therapies, this is clearly a desirable goal for AI. It can facilitate patient care seamlessly. I think you want something like that.
Sean, I saw a couple of questions in the chat about FDA approval, so I could touch on that briefly.
Yeah.
But AI algorithms for medical imaging and imaging interpretation, especially cancer detection, is actually now a class 2 medical device, not class 1. So all you have to do is go through the 510K pathway and show non-inferiority to computer-aided detection for mammography. It's an extremely low bar. So the other thing to mention about the FDA is that they are trying to change their guidance for AI in medical imaging and other fields, but they're a little slow. And the way they are looking at AI algorithms for medical imaging are as static tools. So meaning that your AI algorithm today, even though theoretically it can improve over time, you're getting FDA approved for your algorithm as it performs today. And so if you end up actually iterating and improving your algorithm to a point where you think you could use it for more clinical indications, you have to get reapproved for FDA approval for those new clinical indications. It seems ridiculous, but that's how they're approaching it right now.
Yeah, any algorithm which is for workflow or segmentation, workflow, anything that doesn't involve diagnosis or computer-aided diagnosis type, I think those are relatively easier to get approval for. But I agree with everything else Christoph has said. Sorry, I interrupted someone.
No, you're fine. I'm just wondering, do you guys think at a certain point, dream challenge will influence how AI approaches them? Is that the goal, like the long-term?
Yeah, I think the goal is to have some iterative process where you could get FDA approved for algorithms that continuously improve. And for the FDA to somehow see that continuous improvement over time. They're not there yet in terms of their guidance, but they're working on it. I also saw the question from Tim saying that, putting together huge data sets is a huge effort. And is it really a good scalable way to externally validate AI? And what I would say is that when you're building big data resources, not to use it for just one thing. So Northwest Score, for instance, we are collecting a vast amount of data, but we're collecting information about women-level risk factors, about diagnostic workups, about education levels, about where they live, in addition to all the tumor-level data, imaging-level data. So that becomes a big data resource, not just for AI, but for other important questions. For instance, we're using data from Northwest Score and other breast cancer surveillance consortium registries, and just got funded by the National Institute of Minority Health and Health Disparities to look at disparities in diagnostic workup in our populations. So I would say definitely a good way to externally validate AI algorithms and to have it there as a resource to validate new algorithms as they come about. But if you're going to develop a large data set like this, have multiple purposes for it.
Great, thank you.
We are just about at 2:30. I think we should close this out now and end on time. And I want to thank everyone for attending and for the presenters. And Noah, thank you so much for kicking us off today. And we will see you again in 2 weeks. We have Dr. Anant Matabushi's presentation from Case Western. You'll see the advertising go out for that here shortly. But thank you very, very much for attending. Really, really enjoyed this presentation and I'm looking forward to the next ones. Thanks so much.
Thank you all. Thank you, Sean and Noah.